Hey, good evening. This is Dr. Babbar here. We will get started here in maybe a few seconds. Just let last few people trickle in. Thanks so much. I had to push the webinar back about 15 minutes. I just kind of had an emergency case to kind of finish up so that everything went great. So we're in good shape. Um, so Yeah, it's 5:15. I think, it's already pushed back. So let's get going. So today we're going to talk about men's health, men's wellness, and specifically erectile dysfunction, what it is, what treatment options we have in the status quo, and how we can hopefully um, help patients who are suffering from this condition. Um, so as I said, my name's Dr. Paurush Babbar. I grew up in Melbourne, Australia. I moved to the U.S. for high school, and I did that in Atlanta, and then I went to Wake Forest for undergrad and medical school. And then one of the great things that happened in my life, luck and hard work all came together. I matched at what I consider the preeminent urologic institution in the United States at the Cleveland Clinic. And so I did my residency there, 6 years training. And there I was exposed to a vast breadth of urology, ranging from kidney transplantation to kidney stones, cancer, female urology. But what I always kept coming back to, what was always my passion, was men's health, genitourinary reconstruction, prosthetic surgery, erectile dysfunction. And so I was lucky enough to be able to stay on for another year of extra fellowship training with Dr. Ken Angermeyer and Hadley Wood, who are some of my closest colleagues and mentors, and who I've just learned so much from. And I've brought a lot of those techniques and teachings from them and their years of experience down to Cincinnati, and really happy to be with the Urology Group now. So I see patients out of Eastgate and Norwood offices, and so those are some of my specialties. All right, so what is erectile dysfunction? Who has it? What causes it? So erectile dysfunction is quite simply defined as an inability to achieve or maintain an erection firm enough for sexual intercourse. So the main thing is this is a subjective definition. So for what for one patient, what may be they're happy with, for another patient that may not be adequate. And so we want to talk to the patient, take a full history and physical, and really understand what bothers you about your sexual health, erections, rigidity, curvature, and we try to help address that. So 1 in 5 American men over the age of 20 will experience ED in their lifetime, and more than half of men over the age of 50 have some degree of erectile dysfunction. This stat is interesting because 40% of men in the United States have ED once they're over the age of 40, and that's young, but patients are kind of at times a little surprised to hear that. So I think that people say, why does this happen, right? And we're certainly going to take a deep dive into that. But I think a lot of it has to potentially do with stress. It has to do with our diet in the Western society, things that cause heart attacks like cholesterol, atherosclerosis, those plaques in the blood vessels can definitely cause erectile dysfunction. Diabetes is a big cause of erectile dysfunction. The increased blood sugars damage the inside of the blood cells and the nerves that run to the penis. Surgical procedures down in the pelvis, colorectal surgery, radiation, prostate surgery. I mean, the list, medications, the list is quite long. So it's very important to see your urologist and kind of take a deep dive into this and really understand, do you have modifiable risk factors that we can help with, and what medications or interventions can we do to help manage this absolutely critical part of your life. So what is an erection? So this is a bit of a complex slide, but the way I think about erections are, it's blood flow in and blood flow out. So if you have more blood flow into the penis than is blood flowing out, you have an erection. If you have not enough blood flowing in, that's going to be erectile dysfunction. Or if blood flows in but it leaks out, or then that's another issue. So that is simply what it is, and this kind of talks about the mechanistic way erections work. And so when I think about erections, I try to understand, arterial inflow, venous outflow, and then also the nerves are very important too, and conditions that affect all that we want to look into. So erectile dysfunction can certainly correlate with poor overall health. So we do know that in certain younger patients, in patients who may have erectile dysfunction in their 40s, let's say, I a lot of times would advocate that they see a cardiologist sometimes, just to make sure that their heart is in good shape. Because once in a while, we find that erectile dysfunction is the first indicator of cardiovascular disease. And so this is something that, the heart is it's the ultimate organ. And if that's not working, nothing's going to work. So we're very aggressive at looking into that. Um, so, um, Other causes, like I alluded to, for erectile dysfunction, medications, certain anti-testosterone medications that people use for cancer, certain psychotropic medications that the psychiatrist may give for depression, anxiety can affect it. Not saying we should have you stop those, but it's certainly a conversation that we would have with your other medical providers. Pelvic surgery, very important if you've had colorectal cancers or resection down in the pelvis. Prostate cancer surgery can do it. Then radiation for whatever malignancy potentially down in the pelvis is a big cause of erectile dysfunction. Low testosterone, very important, something that we like to screen for in most patients. It can be an underlying cause of erectile dysfunction. And then certainly, I think one of the absolute top causes is your mental health. That is so important, and that's something that we absolutely I cannot underscore enough. So looking into depression, anxiety, with COVID, life's been stressful, no doubt. And so that I've seen more erectile dysfunction in the past year than in previous times, was it's just created a myriad of issues for patients. So certainly in this slide, we have heard this from elementary school. Do you want to have a good diet? You want to sleep well, exercise, maintain a healthy BMI, lose weight, limit alcohol, definitely quit smoking. Smoking is terrible for your erection. So if that's something that patients are doing, I always think that's very important. That's a very important modifiable risk factor for your overall health, let alone your erections. Reducing stress, sleep. So all these matter. So kind of more of a look into urologic issues that are related to ED. So low testosterone. So 40% of men over the age of 45 can have low testosterone, and this percentage certainly gets higher as men age. Peyronie's disease. So this is an adult acquired penile curvature. 9 to 13% of men over the age of 50 have this, and this is vastly undertreated because guys just don't want to come and talk about it. So this can go hand in hand with erectile dysfunction a lot of times. And then certainly prostate cancer is something that urologists treat, and some of it's not the actual prostate cancer generally, but some of the treatments that you have to do to take care of the cancer that can go hand in hand with erectile dysfunction. So looking at low testosterone, the man's body produces testosterone through mostly the testicles, and as we age, a lot of times that the testosterone levels can dwindle. And so some of the signs and symptoms of low testosterone: fatigue, loss of energy, decreased muscle mass, increased body fat, loss of hair, hot flashes, low libido or sexual drive, and then erectile dysfunction. So, we certainly want to look into that, and it's in the American Urologic Association guidelines to at least offer or check a testosterone level prior to initiation of erectile dysfunction treatment. And so some of the treatments that we would kind of talk to you about when you come and see us are testosterone. There's gels, solutions, there's oral medications, nasal sprays, patches, injectables. So, and we tailor that depending on your situation, and we go from there. And we have a really good system and protocol through our pharmacy and our pharmacist Melissa Reuter, who is just world-class, top-notch pharmacist. And we have the prescription ready, and more importantly, we check your blood work. So there's a lot of these low T clinics that are just going to bring you in twice a week, shoot you up with testosterone, and then just let it ride. Yeah, you're going to feel great, but it's when your testosterone is unregulated, when you do too much of a good thing, it can definitely be a bad thing. And we've learned that from when we were young, and that certainly applies to testosterone. If you let your levels go way out of control, that's when you hear about these negatives with testosterone: heart attack, stroke. Yeah, absolutely, that can happen. So we monitor it very closely to make sure you're in a very tight range that is dictated by the Society of Sexual Medicine. And so we want to make sure that it's healthy, and most importantly, and make sure we get your symptoms under control. So next is Peyronie's disease. So what this is an adult acquired penile curvature, and this can cause loss of length of erections. And we think that this is due to, a lot of times, erectile dysfunction can be the underlying cause. So when you're having sex and you have an erection which is, it's pretty rigid, but not what it used to be, and you have a little bit of hinging when you have sex, maybe imperceptible to you and even your partner. There can be some micro tears in the inside lining of the penis called the tunica albuginea. When that happens, there can be scar tissue deposition, or what we call a plaque, in that area of a micro tear, and then this can cause some tethering of the erection, and then it curves. And then the issue is when you have a curved erection. Where am I? There we are. So you have a short side to the penis and a long side. So both my fingers are the same length, but now one is significantly shorter than the other. And so it's important to, when we first start, patients start seeing this, to come in and you speak to us, and there's certainly things that we can help with that. And so some of the treatments for Peyronie's disease, there's traction device called Restorex out of the Mayo Clinic, which works well. There's Xiaflex, which is an injection, multiple course injection that we put into this fibrous plaque that you can see in this diagram to help break down the scar tissue. And then there's a few surgical options, essentially, to straighten the penis. And we would have to kind of see what your degree of curvature is. Is there pain associated with it? Is there erectile dysfunction associated with it? So in a lot of patients, I think if you have moderate to severe erectile dysfunction and Peyronie's, it's best to actually just do a penile implant in that case, because it addresses the erections and it straightens the penis, and that's certainly the gold standard. So it's something that needs to be evaluated. Prostate cancer, so second most common cancer in men after skin cancers. Very common, and we see a lot of this. And so it's not the actual, like I said, prostate cancer that causes the erectile dysfunction. Generally, it's some of the treatments to that are absolutely needed, and we totally stand behind. But some of these treatments, such as radiation, seeds, surgery, hormones, cryo, they can cause some damage. It can be to the blood supply, to the vasculature, to the penis, or to the nerves especially. So we do see that after some of these treatments. And so most types of erectile dysfunction can be treated, and that's why it's absolutely important that we have you come in and see someone who's trained in a lot of these techniques. I think I just do just doing having a practice solely focused on men's health. I just see that we're too macho for our own good. We don't go into the doctor until sometimes it's too late, and so things are always treatable, more so when you catch them early. When you do things about them earlier, you lose less length. You may not need an implant. You can do less invasive things. So it's everyone who's tuned in tonight, I applaud you. This is a great first step, and certainly you want to just keep an eye on things and come in and see us if there's any issues. And so so these are some of the treatments for erectile dysfunction. There's oral medication, vacuum devices, the Alma Duo ultrasound wave therapy. So this is kind of a newer treatment option that some people may not have heard of, that we'll kind of introduce to you all tonight. Injections, and then penile implants. So the oral medications, so these are medications like Viagra, Cialis, Levitra, Stendra. So these are what we call PDE5 inhibitors, and these increase blood flow to the penis, quite simply. But they do obviously require some sexual stimulation. You can't just take it and hope for the best. I mean, you do need some stimulation with it. And so they're effective at first in 50 to 85% of men, and a lot of men who are on it. People ask me which one's better, Viagra or Cialis, let's say, and I'll say I have half my patients on one and half on the other. It's just which one works better for that patient, and we may have to try one and the other, and then the patient decides. A lot of times it is not as effective in men who are diabetics, who have had prostate surgery because there's an anatomical issue, or even radiation for prostate cancer. So that's something that we look into. Rarely covered by insurance for the amount that's generally needed. So insurance coverage can definitely be spotty at times. And so here's some of the side effects: headaches, facial flushing, congestion, and prolonged erection. The reason a lot of these first three happen is because the same mechanism that increases blood flow to the penis, it also increases blood flow to your head, as you get a headache, or flushing. You get like beet red from it. So that's kind of why that happens. So just the two most common medications we prescribe, Viagra and Cialis. So Viagra takes about 30 to 60 minutes to work, lasts about 4 hours, and it must be taken on an empty stomach, which can be a bit of a rate limiter for patients. So then Cialis is we call the weekend pill, because they claim it can work up to 36 hours. So you got to take it at least an hour before to work, but maybe 2 to 4 hours, and can be taken with or without food. And there's also daily options, and that's generally if patients have a diagnosis of both enlarged prostate and erectile dysfunction. So you can give a 5 milligram dose that can help with that somewhat. So like I'd mentioned, insurance coverage can be quite spotty on this. So this is something to also look into. Our pharmacy, we do offer these pills. We bypass insurance. And for instance, I know we sell the Viagra pills for about 60 cents a pill. There's no waiting in line. The prescriptions are mailed discreetly to your house. We're not like a Men's Health clinic where we're going to take a few $1,000s in membership costs or anything like that. Just a pharmacy. So, and then Melissa Reuter, our pharmacist, is always there to answer any questions. So, it's a good service. So, vacuum erection devices are another treatment option. So just to kind of show you what it looks like. So this is a hollow plastic tube that's placed over the penis. There's both hand and battery powered pumps, and essentially they pull blood into the penis, and then that little black band that you have, a constriction band that's placed on the base of the penis, just to kind of essentially trap the blood in. And I think these work well. The issue, a lot of patients decide to move on because it can be a little cumbersome. It kind of kills the mood a little bit. The spontaneity may not be as good, but I think I have certainly have patients who are on it. Certainly, when I see patients who are undergoing prostate cancer, let's say prostate removal for prostate cancer, after their prostatectomy, we may have them on a vacuum erection device to help preserve length as much as possible, and just to cycle some blood into the penis. So, it certainly is something that can be used. So, ultrasound wave therapy, another name, penile shock wave. So this is something that I'm sure a lot of people may have heard on the news or on the radio. So a lot of ads about this. So what penile shock wave is ultrasound wave therapies that helps to create micro trauma in the inside lining of the penis, and can help bring nerve cell proliferation, stem cell proliferation, and blood vessel formation in the penis. Now the key with this is that there's two types of ultrasound wave therapy. Okay, so there's radial shock wave and focal. What this means in layman's terms is that the focal shock wave is the one that has all the clinical trials out of randomized clinical trials out of Europe and Israel. It is and we are the first group in the city of urologists to offer it. We took a while to get this, because we wanted to be able to stand behind something. I think that was the key, because I'm not going to go up and offer something that I don't believe in myself. But now that there's randomized trials about it, I think that it could certainly help in the right patients. And those patients are the ones who are, either have mild ED or are on Viagra or Cialis and have some response. And in those patients, it can help to promote some blood flow and nerve regeneration in the penis. Now, the other type of shockwave, some of these other Men's Health clinics that you hear in the news, they generally have radial shockwave. So this can be run by anyone. Okay, so this is an FDA class 3. It is like a photocopy machine. It is not really a medical. It doesn't need a doctor to administer it. So, I tell all my patients, always know who is running it, have they done a urology residency and fellowship, what's their training, like what gives them training to work on your penis. Okay, so that's all I'll say about that. So some of the benefits: there's no expected side effects, no downtime, no pain. All the randomized trials showed there was no evidence of penile hematoma, which is a blood collection, penile pain. And they can potentially eliminate or reduce the amount of medications you use, or the dosage, or the frequency. So can be used as a longer lasting treatment. So So kind of I alluded to this, how it works. These are low intensity shock waves. So we, as urologists, we've been using shock waves actually since the 1980s for kidney stones. So if anyone in the audience had kidney stones, you may have had a treatment to break up your stones. It's a little bit different, the amplitude and frequency of the wave, but it's the same principle essentially. So the therapist will treat multiple areas on your penis per our protocol that's been clinically validated from these randomized trials. And I think we have a video that we're going to kind of show about this. So this is the handpiece that emanates the ultrasound waves, and we put it on certain places in the penis that can help stimulate blood flow through the corpus cavernosum, which are the two paired erection chambers at the top aspect of the penis. And so, yeah. So that's just, we're going to show the animation there. And so generally, we recommend 6 treatments over about 3 to 6 weeks, generally 3 weeks, but can be up to 6. And obviously the first question always is, what's the cost of that? And so it's $2,000. So we do, it's $400 a treatment, but if you do all 6, you get the last one free. So we're the first group of urologists in Cincinnati who are offering this technology. We have a staff of experts with decades of experience, and we have a consultation with you to kind of go over things and go from there. So. And here's just a QR code if so anyone was interested, and here's the number directly to the Alma Duo team to get the ball rolling on that. Good. And one thing is, I will answer questions at the end. So in this chat box, if anyone has questions, please feel free to type them, and we'll take any and all of them. Okay, so another treatment option for erectile dysfunction are injections. Okay, so these are you take a small amount of a medicine which is very potent and can increase blood flow to the penis. And so instead of taking a pill that, as we saw, had some side effects like facial flushing, headache, you're putting it directly into the penis. And so it helps to really get a nice, firm, rigid erection. About 60 to 80% of men, I think, will achieve and see success with this. Reasons that patients may kind of move on this, you're putting a needle in the penis, and so that this can be some pain or bruising associated with it. And then I think a lot of times the spontaneity can be a bit of an issue, because these medicines generally have to be in the freezer, and you got to thaw them and then pull it out a little bit and then inject. So it takes about 5 to 20 minutes to kick in. So that whole spontaneity aspect can be a bit of an issue, but I have a lot of patients on penile injections who swear by it, and I think it's a very good option. So this is how it's done. You self-inject at the base of the penis at either 9 or 3, so that way you avoid the urethra and you avoid the nerves. The erection will typically begin 5 to 20 minutes after injection. Now, like I said, has to be refrigerated, actually frozen a lot of times, limited shelf life. So if you leave it out on the counter overnight, it can actually go bad. So you got to be careful about that. And this is not something you can get at like Kroger, Meijer, or even our pharmacy. This is a compounded thing. And so we have some pharmacies that we titrate the doses through and get it sent to you. So. And then the last, so everything before this slide was the medical management of erectile dysfunction. So medicines and ultrasound wave therapy, vacuum devices. This is the once those have been exhausted, and we're still not, patients are not having as good an erection as they would like, then we move on to penile implants. So a penile implant, let me just show this. So essentially, it's a device that is implanted into the penis. There are 2 cylinders that are placed in the 2 corporal bodies, or the blood chambers of the penis. There's a pump that's in the scrotum, as you can see, and then there's a reservoir of fluid we tuck in the abdomen. So all of this is imperceptible. You can't, if you're in a locker room, no one should be able to see it. You can go in an MRI machine and it's safe. You can go in an airport metal detector, it will not set it off. And so essentially, when you want to have intercourse, you just locate the pump that's in the scrotum. You give it a few squeezes. It pulls the fluid from that reservoir into the two chambers of the penile implant, and it gives you a nice, firm, rigid erection. And when you're done, you just press this little. There's a little check valve like that releases the fluid, and then that fluid goes from this implant back into the reservoir. So that's the inflatable type. There's other types. There's a malleable. There's where you just have these two rods that are in the penis in patients who don't have good hand dexterity or who have a prohibitively high infection risk, for instance. We might consider it. But I think this is a very good option. The surgery takes about an hour to an hour and 15 minutes to do. Go home the same day. Wait a few weeks for it to heal up, and then you come back and see us. So main complications with a penile implant. Just like any artificial implant in the body, like a knee, artificial hip, heart valve, there is a 1 to 2.5% risk of infection. So we do a lot of things to mitigate that risk. The way we give you a soap before surgery to use, we scrub in a certain way, we shave the hair in a certain way. So a lot of things that are data driven that we do. And then because there's fluid moving back and forth in the inflatable penile implant, there is a risk, just like your car tire can pop a leak, that there could be leakage of fluid, and then the implant stops working. The risk of that is 6% at 7 years, so 94% or 19 out of 20 will still work 7 years after implantation. Yeah, so this is I think a very good option in patients, with severe erectile dysfunction or erectile dysfunction plus Peyronie's, and this can help straighten the penis. So this is certainly something that only a urologist can do, and so something to certainly engage with your urologist about. So in summary, I just want to thank everyone for tuning in tonight. Very important topic that I think we want to get the word out about, and we have a variety of treatment options. So definitely come in and see us, come in and see me, and I would love to just have a conversation and get an individualized solution that works best for you. So I think we'll move on to the questions now. So if anyone has questions, please go ahead and just type them into the chat, and I'll just start taking them one by one. Okay, so here we go. First question: for the implant, the pump in the scrotum seems like it would be uncomfortable. So yeah, that's a good question. Generally speaking, I think patients will state that it is a new piece of hardware right there, but most patients get used to it pretty easily, because the scrotum is quite lax. The skin is very lax, and so generally that's not an issue. When we first teach you 4 to 6 weeks after how to inflate the device, it's a bit of a learning curve. It's just like learning to drive a stick shift or something. It's a new toy that you have to learn to work, and I just have patients inflate and deflate it twice a day for the first 2 months or so, just to get a feel for it. You do it in the shower especially, it's good, better, because the skin will loosen up from the hot water, and then you can just feel the implant better. But generally speaking, I patients have done very well with that. Maybe one patient who was really bothered by it, but over time I think he's been great. So but very good question. Next, what brand of implant do you usually use? Yeah, good question. So I generally use the Boston Scientific AMS brand. The reason I do this is at the Cleveland Clinic. That was exclusively what we used. In my hands, I think it works better. I like the implant most. One of the big reasons is there's an inhibizone antibiotic coating on it. I think this is absolutely critical, because the thing that worries me the most, that keeps me up. So I did close to 100 implants last year, and what keeps me up at night is the risk of infection, right? It's 1 to 2.5%. It's low, but for those patients, and it's hell, and it takes it out of me. It's the worst when we see that. So any implant that can decrease that risk, I think, is the absolute key, right? So that is number 1, 2, and 3. Now, I like the pump better on the Boston Scientific device. I think patients are able to use it a little better. I think it's just makes more intuitive sense. And I think it's just in my hands. We've had good success, and like I said, at the Cleveland Clinic, we're using that exclusively, and they've used it for over 30 years. So that's what I go with. Are there specific reasons you would choose to screen for low T or prostate cancer? Yeah, so we can take those one by one. So low testosterone, I generally screen for that if patients come in with symptoms such as erectile dysfunction, low libido or low sex drive. And then if they're saying, I'm having fatigue, concentration deficits, increased weight gain, loss of muscle mass. So when you kind of start hearing that, I a lot of times will check a testosterone level with a few other hormone levels just to understand, is this the issue? Sometimes it's not, right? So then I would say, go get your thyroid checked, get your have your primary care look, is there depression, anxieties, or something else going on? So but those are some common reasons. And then when do we check for prostate cancer? So per the American Urologic Association guidelines, we want to check patients between the age of 55 to 69 with a PSA every year, every other year for prostate cancer. And then sometimes we do it at a little younger of an age if there's a very strong family history in the African American population, because there's higher risk prostate cancer sometimes can be diagnosed. So, but generally 55 to 69, we'll check for prostate cancer with a PSA blood test. So someone asked cost. Not sure of what, but I mean, I guess so. So the Alma Duo cost was, it's $400 a treatment. There's 6 treatments. So if you pay for the first 5, you get the 6th one free. So it's $2,000 for 6 treatments. Now maybe penile implant cost. So generally, what we're finding is we have to run it through your insurance. But for Medicare patients and most commercial carriers, it's covered for the most part. Medicaid generally is not, but once again, we got to really run that. But since with the volume that I'm doing, we our pre-cert team, Cheryl, is very good at this, and we were able to push a lot of these through. So, yeah. Does the implant expand the size of the penis similar to a normal erection? So that's a good question. So with the penile implant, right? So when we think about penile size, right? So if you are getting to the point generally where you need a penile implant, you likely have severe erectile dysfunction that you've been dealing with for a number of years, meaning that you have not had good oxygenated blood flow to the penis. What we know is that every year you leave erectile dysfunction under or untreated, you can lose half a centimeter of penile length up to 2 to 3 centimeters, which is a lot, right? So patients may not notice, but patients who come to this point may have already lost a lot of length. Now, there's no way that we can get your length back to what you were when you were 20 years old, right? Anyone who tells you that, I mean, I think I certainly can't stand behind that, and if anyone can, I would really caution you, honestly. But the penile implant, if people say, what will my length be? So if you just take your penis and pull it on stretch, that's called your stretched penile length. That's about how long it will be, essentially. So however long your skin is, I mean, we cannot make it longer than that, and I mean, if we could, then I'd be a billionaire in the Bahamas, just because penile length is, I mean, that's everyone wants more, but it's hard to achieve sometimes. So now the penile implant, there's a few different models of it, right? So in patients with a shorter penis, we can do a length and girth enhancement penile implant, and so this will give maybe about a centimeter and a half of length and some girth. And then in patients who have a longer penis, you use what's called a controlled expansion device. And so there is some definitely girth enhancement with that. The length is not as much, but the reason we don't always use a length and girth enhancement, is everyone will say, oh, I want that, is because the rigidity on that implant, I find, is not as good as the other one. And so in patients with a longer phallus or penis, when they're having sex, it can buckle. So it's a bit of gestalt, on what to do, but that would be the answer to that. Okay. Okay, hello. I need to make an appointment with you. My erections make a hard left, and it makes it too uncomfortable for my wife. Peyronie's, maybe. Yeah. So this absolutely does sound like Peyronie's to me, especially if you weren't born with that. So there's another condition, I mean, I didn't go into today, but it's called congenital penile curvature, CORD. So I see some patients, in their teens and early 20s who have this, and that's different. So that's a congenital curvature. But if this is a new onset thing you're just starting to deal with, that curvature is likely Peyronie's. And so, yeah, absolutely, please come in and see me, and we want to kind of understand how what is the degree of curvature, how many degrees is it hurting when you have an erection, and then how are your erections. So then that will dictate how we proceed. But I think certainly we want to help, especially if it's uncomfortable for your partner during sex. That is, at least to me, that's an indication to certainly intervene, because we want to help regain that aspect of your life. So, all right. Would there ever be a time you would recommend using Cialis along with an injection, or should I be asking you for a stronger medication for the injection? Yeah, generally speaking, I think if a patient's on injections, I'm not convinced that Cialis is going to help much, unless you're on the low dose 5 milligram daily. That's more for the enlarged prostate. I could see that kind of rare scenario, but generally, yeah, we can up titrate the dose of the injection if you find the rigidity isn't good enough. But just like any blood pressure medication or diabetes medication that patients take, over time, you may need to increase the dose, and then there's a maximum dose where you can't go beyond. And then if we ever reach that, then we head to a penile implant. Or if patients like, I'm sick of injecting my penis or whatever, then we head to a penile implant. All right. Is there a benefit to doing only a couple of the Alma Duo treatments? You offer less than 6 visits. Yeah, so sure. You can, do as many or as little as you like. But the reason we do 6 is that this is what the majority of the clinical trials, the randomized trials, were based on. It was a 6-course treatment over 3 weeks, 2 treatments a week, and some of them you could do it every week. So, that's why I said it could be over 6 weeks. But that's why we do 6. Now, I'll tell you anecdotally, I think some patients are experiencing benefit maybe at the 4th visit. It's not going to just be right away, right? But like I said, like the reason to see a urologist, honestly, about this is, like, if you called and said, "Look, I have had prostate cancer. They took my prostate out. I'm on injections. They barely work." I'm not going to tell you go do Alma Duo. You know what I mean? It's not going to work for you. There's data. There's 4 trials. It doesn't work in patients post prostate. So because whereas a lot of the men's health clinics, that's all they do. So if you have a hammer, everything looks like a nail to you. But we offer everything. So we're going to get you the right treatment. So I think that's one of the main things to look into. Approximate cost of the implant. So I think if it's cash pay, it's about $20,000. But otherwise, but like I said, that I rarely, very rarely do we have to go that route. There's most times Medicare is covered in most cases, and then commercial cares will cover it many times. So very good coverage in most cases. But if someone had to pay fully out of pocket, it's in that neighborhood generally. Can testosterone therapy accelerate prostate cancer? Very good question, contentious question. So what we're seeing is, in patients who do not have active prostate cancer, we can certainly give it. Now, in patients who do have prostate cancer, that's up for debate. Okay, so in patients with prostate cancer, I generally do not give them testosterone. Now, if they've been treated and they've been disease-free for a year or so, we can consider it, knowing that, yes, is there a possibility of recurrence if you give testosterone? Potentially. Why do we know this? Because some of the treatments for, let's say, metastatic prostate cancer actually cut the testosterone level. Like, for instance, back in the day, they would cut people's testicles off before we had drugs that could do that. So, and certainly in a patient with metastatic prostate cancer, I mean, no one would do that. But so I think, generally speaking, we don't have data that it causes prostate cancer, but in someone with prostate cancer, it could have accelerated potentially, right? So we do certainly have some reservations in that setting. So it's a nuanced conversation in that case. I've been taking oral medicine for low T, but I'm still having low libido. Should I ask my doctor for an alternative low T treatment? Potentially, yeah. So yeah, there are some oral testosterone repletion, Clomid, Jatenzo. So if you're still having symptoms, I think talking to your urologist about checking a testosterone level and a few other hormone levels, LH, estradiol, hematocrit, just to see where you stand. And then if those are still low, I think thinking about a different formulation, I think makes a lot of sense. Having Peyronie's disease, no matter the severity, should you have it corrected, or does it affect your erection? Yeah, it's a good question. Generally speaking, lateral left or right curves or upward curves 30 degrees or less, you could probably observe, right? Because you can still have sex and there's no pain to the partner. Downward curves probably 20 degrees or what the partner can handle before it's painful. So so yeah, if like a lot of guys are born with a small tilt to their penis, like a banana bend, and they live life, it's all good. And if you have a very mild curve, I think you can potentially leave it. Now, but if it's causing pain with erections or you can't penetrate, then certainly some type of treatment makes sense. The only thing to think about is that sometimes Peyronie's disease, like I talked about earlier, can be maybe caused by some underlying erectile dysfunction. So getting that treated can certainly help prevent more curvature. Does the ultrasound need to be reapplied? How long does it last? Yeah, this is the $1 million question in the field right now. So we are exploring like touch-up treatments essentially. So and I think it's going to be needed. I think essentially this is not a one and done thing, but these studies are still ongoing because it helps to regenerate some blood flow to the penis. But just like, for instance, let's say patients who get Botox in their face for wrinkles, after a few months they're back, they got to go in and get it again, right? So it's as we age, a touch up, I think, makes sense. And I don't think that's going to be 6 treatments, maybe 2 is what the studies are looking at. But I in my opinion, I think this may be something that the data is going to bear out. Now, how long does it last, right? So the answer to that is the only data I can give you on how long an erectile dysfunction treatment lasts is for a penile implant. Why is that? Because I'm putting a device in your body that will it's mechanical. It doesn't matter how you age, how your diabetes is controlled, what you eat, if you get cancer, if you have surgery down there, right? So that will work 94% of the time 7 years after implantation, right? I can answer that, no question. Now, I can't answer that question for Viagra, because let's say someone, I put him on Viagra, he has a great response, but then he gets diagnosed with diabetes, he's not taking good control of it, that could fail within 2 months. But I have guys who've been on Viagra for years, right? So the issue a lot of times why you can't answer that question is the modifiable patient factors are a big part of it. So there's no answer to that at this time for any of the medical treatments, is what I would say. What is the maximum units of the injectable medication that should be used before going to stronger medication? That depends on the dose you're on, but a lot of times, I mean, that's hard to answer, I think. I mean, that's very individualized, but I tell patients if they're using like half a cc or 50 units of whatever medication, then that's a lot above that can be a big volume for the penis. So you may want to at least consider increasing the concentration of the injectable medication. I'm injecting testosterone, but still not getting the erection. I get the headache, facial flushing, and sinus situation and cannot perform correctly. What can you suggest? Does testosterone affect my body or organ by not performing sexually? Okay. So I think so. Just by repleting your testosterone doesn't necessarily mean it's going to get your erections back, right? So I think sometimes the treatment, like if you didn't treat your testosterone, then like let's say Viagra, Cialis, or injections into the penis may not work as well. But just doing the injections for testosterone is not going to, in of itself, get your erections to what they were, right? So that's one. So first thing is I would check what are your testosterone levels, right? Do you need to be up titrated and things of that nature? One. Two is depends what you're taking for your erections. If it's, let's say, if you're saying you have headache, facial flushing, it may be that you're on some type of Viagra or Cialis, that maybe you need to be kicked up to vacuum device or injections or things of that nature, or penile implant. So, I think it's you probably see your urologist to get a better understanding of or grasp of that, and go from there. How often should I get my testosterone level checked or continue testosterone prescription? Yeah, so that's a good question. So the guidelines we'll talk about is when you start testosterone, you probably want to get it checked 1 to 2 months after, and then until you get, once you get on a steady dose that you have good testosterone levels with, you can generally check it maybe 6 months after that, and then yearly thereafter should be fine. So that's generally what we do, but obviously that can be individualized too. Okay. Patient says, I don't smoke or drink, never had insurance or health problems, have health insurance now. Should I find a primary care physician first, maybe be screened for everything, anything before coming to you? No, I think absolutely. I mean, there is good evidence that having a primary care doctor just to look all over and do a thorough history and physical is absolutely critical. So I would absolutely encourage you to get a primary care doctor and look into that. But concurrently, please come and see me, and let's talk about sexual health. Because a lot of times, the primary care doctors, they have other things, to go over with you, and so we can work on things concurrently. um how long will the effects of the Alma Duo last? Hard to know. I mean, like I said, in the sense that uh there's a lot of modifiable factors with it. This is not a thing that it's to kind of help your whole body get more blood flow and nerve cell regeneration to the penis. So this is to kind of uh, you know put fertilizer in the soil so that things can grow. And I got to think of a better analogy, but hard to know. If you found injections to work on getting an erection, would you recommend Alma Duo treatments? Good question. I think it's divided on this answer. I think right now I'd say no to you, because I think that some people say with patients who have or on injections, the Alma Duo may help. I'm not convinced, to be honest with you. I think that if you're on injections already, I think it may. The data is much better on patients who are on the Viagra or Cialis. So probably just not proceed with that. What is a typical Cialis dose and what are safe higher doses? I get no flushing with 20 milligrams. It works inconsistently. Yeah, so 20 milligrams is the top dose. So that, you certainly, the FDA does not want you going higher than that. Yeah, if it's working inconsistently, you can't really go up on the dose. Maybe worth coming in to see us, because part of sex is you want to be able to rely on your erection, right? You don't want it to fail you when it's time, because once it does a few times, is then you start getting in your head like, is it going to work this time? Oh, and that doubt can be absolutely an issue. So I think trying maybe something else like injections or penile implant is something to consider. So yeah, come in and see us, and we can chat. So what are doses of Viagra? Is it safe to take 2 pills? Yeah, so Viagra's maximum dose is 100 milligrams. So the 2 pill thing, it depends what denomination of the pill. You can get 20, 25, 50, 100, right? So if you generally, we give the 20 milligram pill because that's the most cost effective as the generic. So certainly if you have 20 milligrams, you can take 2 pills. But if they've given you the 100 milligram pill, then no. So yeah. All right, that's all the questions. Thank you so much for everyone for tuning in this evening, and yeah, I look forward to seeing you in the office if there's ever any issues I can help with. Thank you so much.